you have been chasing the inflammatory hypothesis for a long time. Tell us about that history.
Well, it's been almost 25 years of focus really on one fundamental question, which is why do half of all heart attacks and strokes occur among people who don't have hyperlipidemia and maybe 25% who don't have a traditional major risk factor. It was over 20 years ago we published our first major paper saying if you measured inflammation with what we now call high sensitivity CRP, that you could pick up people at very high risk for heart attack and stroke who've been missed by traditional screening. And it was 19 years ago that we actually showed that statins are great lipid lowering drugs that are actually anti-inflammatory. And it would take us until 8 or 9 years ago to show that if you had a high CRP and a low LDL, you better be on a statin. That was our Jupiter trial. But this whole process, including elegant basic vascular biology from people around the globe, has been pushing an idea. That fundamental idea is, can we actually lower event rates by reducing inflammation without changing LDL cholesterol? And that's where we are today.
Okay. So where are we today? Tell us what you did in CANTOS.
So CANTOS is a very interesting and very large science project where we're altering innate immune function in 10,000 patients for up to 5 or 6 years. I am very grateful to the participants who are willing to do this and the physicians who take care of them who are open-minded enough to say, we know you're at very high risk if you've had a prior heart attack and you have a high CRP. That puts you at very high risk, and our standard therapies don't touch that. It's what we call residual inflammatory risk, very different than residual cholesterol risk. It's a different group of patients. So CANTOS took the residual inflammatory risk patient, high CRP despite being on intensive statins, already revascularized, already aggressively being taken care of, and we found a 5% per year event rate. So that's the first signal. That's a very high risk for the people in the placebo group. And as the dose of canakinumab went from low to middle to high, we saw increasing reductions in heart attack, stroke, and cardiovascular events that quite surprisingly almost mimicked identically what we know is true with a PCSK9 inhibitor. So we learned from Fourier early this year, you have a 15% reduction in events by driving the LDL very low. We had no change in LDL at all and got the exact same 15% on our primary endpoint, 17% for our secondary endpoint, and really interesting, about a 30% reduction in ever needing bypass surgery or angioplasty. And for me as an inflammation biologist, that's exciting because that's the endpoint that really reflects the progression of the disease, which is what we've always thought inflammation is driving.
So, I mean, and that's great news, but you didn't see a mortality benefit. Disappointing news on that?
Well, no, I don't think so. I think that in this era, very few patients die of that infarct. What they get instead is the long-term sequelae of it. Lots of bypass surgeries, lots of angioplasties, lots of heart failure. So the fact that we're having a big impact on that, I think is really the future of this disease. Now, all drugs come with adverse effects. And when you alter innate immunity, you expect to have an increased risk of infection. We did have a statistically significant, albeit quite small, increased risk of fatal infections. So all-cause mortality was actually reduced, non-significantly, about 6%, which was a counterbalance between the benefits of inflammation inhibition and some of the expected hazards of it. Now, one of the extraordinary things about CANTOS is it's what we call systems biology. When I was a medical student, we taught heart, lung, kidney, brain. We don't do that anymore. We teach inflammation, fibrosis, metabolism. This trial is the expression of that. For example, we knew by changing immune function for many years, we would have probably an increased risk of, in this case, infection. We were hoping to show a benefit on cardiovascular disease. We have a reduction in rheumatoid arthritis. We have a reduction in gout. We have a reduction in osteoarthritis. And I think one of the most interesting findings of this whole trial is a reduction in cancer.
Okay. And that's the lung cancer, well, specifically at the 150 milligram dose, this significant reduction in lung cancer. You're actually publishing on that as well. Can you talk a little bit about that?
Sure. So it's interesting to be at a cardiology meeting knowing that I'm going to be presenting a lot of data on cancer. So it's really quite fascinating. The same inflammation that drives the atherosclerosis is also a driver of certain kinds of cancers that we call inflammatory cancers, where there's a pro-inflammatory response in the tumor microenvironment. The classic example of this is lung cancer. If you smoke a pack of cigarettes, you're chronically inflaming your lung. If you breathe in diesel fuel or asbestos, you're chronically inflaming your lung. That's been known for a long time to increase the risk of lung cancer. What's fascinating is we have a dose-response reduction in all-cause mortality from cancer of 50% at the highest dose, and a 75% reduction in incident lung cancer. And again, lung cancer mortality down by more than 75% as you go across these doses. Big caveat here. This is turning cancer research a little bit on its head. Normally you start with very aggressive advanced disease, you get standard treatment, and then see what we can do. These are cancers that our patients didn't even know they had. These are undiagnosed cancers equally distributed in the 4 arms of the trial, that they receive this powerful targeted anti-inflammatory drug as part of the atherosclerosis study. And our hypothesis is we blocked the progression and invasion of that tumor. We now have to see, will this work in patients who already have a clinically evident cancer? But it's very exciting biology, and to be honest, it's going to open up a whole new way of looking both at atherosclerosis prevention and probably cancer prevention and treatment.
So I have 2 additional questions. This drug is approved already, and as a trialist, that's a little bit unusual for you. I mean, obviously you work with an approved drug in Jupiter as well. But often when we see major trials, they're of investigational agents. This is approved. So you report the data are published. Do you think that it's possible that this will encourage clinicians for certain patients to actually begin this therapy, which would be an off-label use?
It's a complicated question. So canakinumab is an orphan drug right now. It's been indicated for quite a few years to treat some very rare pediatric disorders that on a genetic basis have overexpression of interleukin-1 beta. The drug is an interleukin-1 beta inhibitor. So it's a complicated question about, would you use this? My view is I would wait. I would sit down and let the sponsor of the trial try to figure out how they might want to bring this to market if they do. Let the FDA do its piece. I think the bigger issue here is we now know for the first time there's another way to get events down that doesn't change LDL cholesterol. Now remember, everybody should get their LDL down, and I would argue as a preventive cardiologist, if you want an anti-inflammatory treatment right now, go to the gym, get some exercise, stop smoking, eat more vegetables. Those things all lower IL-6 and CRP, and we think part of the reason they benefit is exactly for that reason.
So the other issue is that, as I said, it is approved, it's an orphan drug, it's expensive. And expense has been a problem recently, certainly for the PCSK9s, a huge problem for the expense. This drug, in its current indication, is about $200,000 a year, but that dose would be different than what you're talking about in this trial. Do you think that cost, so much tension on price, that would be something that would make it unlikely that this drug would ever be approved for this indication?
I actually think it's grossly premature to even have any discussion at all about price. Remember, it's an orphan drug. If the sponsor elects to get a labeling indication for atherosclerosis, they're going to lose orphan drug status. And so you can't use current prices to make any discussion thoughtfully at all. The bigger question again is, this is opening the door. This is like going back to lovastatin or simvastatin some 20, 25 years ago. This agent has proven the hypothesis is true. The cost issues will play themselves out for this. The question becomes, what else might there be in the pipeline? We're doing a clinical trial funded by the National Heart, Lung, and Blood Institute using low-dose methotrexate. That's a generic drug. It's pennies a week. We're about 2 to 3 years away from knowing whether or not we'll get a similar response. And remember, this is not inflammation writ large. It's a very specific kind of inflammation. So this is not about Motrin or ibuprofen. This is about, right now, targeted IL-1 inhibition. But in the future, we don't know where this is going to go. It's going to be very exciting.